here in this very important meeting. To come to your question, sir, why this residual risk is never addressed, I think the answer lies that we actually still don't completely understand the reasons for the risk of cardiovascular disease. So, as you said, can I start my slide, please? Please allow me to share. Your point, sir, that the reason why we continue to have residual risk is because we still don't completely understand the mechanism of the risk in coronary artery disease. We know some of the factors that lead to the risk, but once we address those factors, the residual risk persists. And so the endeavor that I am going to do today is to try to cover the ADA 2022, which has found, has shed some light on this area. And I will make refer to two presentations that were made, which will throw some light on what is going on. So, coming to the risk of coronary artery disease, we know that the statins, they are the first ones probably among the major drugs that were found to reduce the risk. And you can see that statins reduce the risk over a period of time consistently from let us say about 30% of risk they can address, but still there remains some residual risk. So at most, statins can address 30% of the risk associated with coronary artery disease. So the issues are that, as I said, statins lead to mortality reduction by about 30%, but 70% risk is still unaddressed. The reasons could be multifold. Number one is that plain statins may not lead to complete correction of dyslipidemia in all the cases. Number two, the effects of statins are variable. In some of them, they lead to a lot of benefit. But in some situations where other factors may be operative, like for example, diabetics, they may not completely address the total risk. So I think these are the issues with the statins. One of the factors identified particularly in diabetes is this factor of hypertriglyceridemia, which is found to be an independent cardiovascular risk. And meta-analysis of these 17 studies shows more than 55,000 patients that for every increase in triglyceride level of about 90, the cardiovascular risk increases by 32% in men and 76% in women. So clearly, one of the hypertriglyceridemia may be one of the factors for this residual risk. It may not be the only factor, but it may be one of the factors. So in this view, two presentations were made on this particular related area. One was by Dr. Ronald B. Goldberg, and he talked about drug treatment for residual risk beyond statins. So we know that statins can reduce LDL cholesterol, but may not completely bring the LDL cholesterol to normal values. If you look at newborn baby, we might be surprised to know that the LDL level in a newborn baby is 20. And as the baby grows, the LDL keeps on increasing over the time. So it is likely that the LDL requirement for the body is only 20, and anything beyond that contributes to the risk. So there may be benefit of lowering LDL to very low LDL levels, approaching, let us say 20 or 30. So therefore, there may be a lot of LDL lowering drug which can act what statins do beyond the statins. So STMB, and then this colselvelsan, then PCSK9 inhibitors, and bempedoic acid. So these are some of them. Then the other possibility could be to use drugs that could reduce hypertriglyceridemia, anything beyond more than 150, especially in diabetics. So some of the drugs that can reduce the level of hypertriglyceridemia are fibrates, omega-3 fatty acids, niacin, and some other investigational agents I would talk about what Dr. Goldberg already presented. So this is essentially Dr. Goldberg's presentation. I have just modified it, and The third factor that could be very important could be LPA. And the second study that I will cover, which was presented during this ADA 2022, is that the second study, which I will come to little later. So now let us focus on first the LDL reduction. And we know that beyond statins, these are the drugs, STMB, PCSK9 inhibitors, and what we see is that all of them can bring about a further reduction of LDL cholesterol. PCSK9 inhibitors being perhaps the most effective one among them. And some of the drugs can also address the hypertriglyceridemia as well, and then they may have additional benefit. So these were the two presentations I am trying to cover. The first one I have already alluded to by Dr. Ronald B. Goldberg, and this will be regarding drug treatment of radial risk beyond statins. The other one would be the LPA, important cardiovascular risk factor, which was presented by Joseph L. Witsum. So now coming to the first presentation, we see that these drugs I already alluded to are useful in reduction of LDL cholesterol. Some of them can in addition also impact on hypertriglyceridemia, but most effective among them, as you can see from the chart, is the PCSK9 inhibitors. So now let us look a little bit at PCSK9 inhibitors. We know that it is a monoclonal antibody, and two varieties, one with E and A, and they interfere with RNA of the PCSK9, and what they do is ultimately they can increase the LDL receptor numbers, and they can increase the LDL clearance in the body. Pretty safe, except that they might have mild immunogenicity. Otherwise, more or less, they are quite safe, but they have been to be given in an injection form, either fortnightly or even monthly. Now, what do these studies show? So, if you look at these two molecules that or three molecules that we have now, evokumab, alirocumab, and inclisiran. These are the three drugs that are available with us now. As you can see, all of them lead to a remarkable reduction in LDL cholesterol beyond what statins can do. So more than 50% reduction by what is achieved by plain statins. But at the same time, another good thing they can do, to some extent, they can also, all the three drugs can also reduce the triglyceride levels. And of course, they reduce the non-HDL cholesterol level. They can also reduce ApoB levels by about 50%. And also reduce LPA levels. So basically, and moreover, they can improve the HDL cholesterol or the good cholesterol. So we see all the beneficial effects with the drug, some more, some less. LDL cholesterol reduction by about 60%, ApoB reduction by about 50%, and then triglyceride improvement, non-HDLC improvement, and LPA improvement, and also increase in good cholesterol, that is HDL cholesterol, little bit, but still happening. So basically a win-win situation in all the lipid parameters. What about the clinical evidence? Both these drugs, the clinical trials that are available with evolocumab and alirocumab have shown that they lead to a reduction of MACE, both of them. So not only they improve the lipid profile, they can actually reduce the clinical events beyond what statin is able to do. So clearly a drug that that impacts upon the residual risk beyond what statins can do. Now coming to this second drug that is available with us, which is bempedoic acid. Mechanism is by ATP citrate lyase action, and what it does is it improves little bit or reduces little bit LDL cholesterol, HDL cholesterol, ApoB, but also the inflammatory marker, that is the high sensitivity CRP, that we saw an effect which is also like statins, because statins also reduce the inflammatory markers. On the other hand, if we come to the third drugs that are available with us, the fibrates, The mechanism of action is by impacting on the fatty acid and lipoprotein metabolism, and not only that, but also on many other genes. It can also do a lot of things, as you can see. Unfortunately, the clinical impact is not much, and while it can reduce the triglyceride level, its impact on LDL cholesterol is not much, and HDL cholesterol it slightly increases. So its main effect is on triglyceride, but the benefit on LDL and cholesterol is not much pronounced, and at the same time it has got not a lot of associated problems. For example, it can reduce the comedine dose, it can increase the serum creatinine levels, it can elevate the liver enzymes, and it can also cause myalgia. The clinical benefit also, if you will see, interestingly, when given in conjunction with statins, when the patient is already on a statin, there is no great clinical benefit. On the other hand, if somebody is statin naive and you cannot give statin for certain reason, there the fibrates may have some role and it may improve some of the parameters, but only in those cases where you cannot use a statin for some reason. So in person who's already on a statin, there is no further reduction of risk beyond what statins can do. Same thing coming out. Therefore, what we can conclude is that while fibrates can reduce the level of chylomicronemia, if the triglyceride is more than 500 mg/%, it can be helpful, and it may have some role in diabetic retinopathy as well, but its role in reducing the cardiovascular risk beyond what statins can do is very doubtful and has not shown any benefit. This is prominent study is one large phase 3 clinical trial which showed that fibrates don't work in this area. Now coming to the fourth drug, that is the omega-3 fatty acid preparations. As you might know, there are three types of omega-3 fatty acid preparations. One is omega-3 ethyl esters, the other is omega-3 carboxylic acids, and third is the eicosapentaenoic acid or ethyl EPA that we commonly call. And the mechanism of action is by impacting the fatty acid and lipoprotein metabolism, and also several other beyond the lipid metabolism actions by omega-3 fatty acid. Particularly, you might remember one action of reducing sudden cardiac death in some of the heart failure patients. So it has got some roles beyond the mere lipid related activity. Now you can see that what this can do is it can reduce the levels of triglyceride quite significantly if you use 4 gram daily, but its role on LDL-C is a cause of concern because it may actually increase in some cases. There is no improvement in good cholesterol. There is no change on ApoB level. Now, interesting thing is that it is well tolerated, fish oils. There could be some side effects in some of the patients, and it can prolong bleeding time in some of the patients as well. However, the trials are very interesting. They show that when you use IPE or eicosapentaenoic acid or ethyls, then the benefit comes out in addition to statins. Other omega-3 fatty acids have not shown that much benefit. So it's basically with IPE that the benefit happens even beyond the usual statin doses. So use of purified omega-3 fatty acids is in prevention of chylomicronemia, just like fibrates. But it can also be add-on therapy to statins, especially if triglyceride levels are more than 200 milligram, and can reduce the risk, especially the risk associated with diabetics. Now coming to nicotinic acid, we see that while LDL cholesterol is reduced, good cholesterol is also increased, triglyceride levels are also decreased. Overall beneficial effect on the lipid profile. Unfortunately, the clinical outcomes are not that good, and many of the trials have shown that the combination with the statins did not work, and therefore this particular therapy is practically abundant now. Now coming to the last modality that I will touch, which is ApoC3 inhibition. ApoC3 is important in metabolism of chylomicrons, VLDL and remnants, and it can be an independent risk factor, and its inhibition lowers the triglyceride levels and therefore may impact, and some drugs are available in this area. One of these drugs is ApoC3 inhibition, and you can see that two drugs are available here, and both of them can markedly reduce the triglyceride level and also reduce the ApoC3 level, through which they predominantly reduce the non-HDL cholesterol. But the problem is that they can increase the LDL cholesterol, and therefore, they have to be a bit concerned with these drugs. But in certain specific situations, they might be helpful. The other drug that is available with us is angiopoietin-like protein 3 inhibition. And again, these studies show that this is a monoclonal antibody and which lowers both triglyceride and LDL-C, and therefore useful in mixed hypertriglyceridemia. Remarkable reduction in triglyceride level by around 60%, and also reduction in LDL cholesterol. So this group might be useful and will require further study, but definitely this group might be useful. The third group of drug that is now available with us is pilacarsen, and this drug reduces the LPA production. And I will show the next presentation by the author, and which talks a bit more about LPA reduction and the benefit of this particular drug, which is pilacarsen. So, one particular trial is also available with this drug. So, basically, to summarize the first presentation, what it is recommended is that there may be benefit of further reduction of LDL cholesterol, and PCSK9 inhibitors are very good in it. The other drug that can be useful is ecopanthenol esters with 4 gram, which can be used to bring down the hypertriglyceridemia whenever it is more than 200 milligram percent, can reduce the risk in patients with cardiovascular risk and diabetes. There is no benefit at the moment beyond the statin of use of fibrates or niacin, but investigational agents show some promise, particularly the ANG-PTL3 and LPA, which I will talk about later. So the second trial that I wanted to, or the second presentation that I wanted to cover was by Dr. Joseph L. Witzman, where he discussed about LPA. And as we know, LPA is a low density lipoprotein variant that contains the protein apolipoprotein A. And we know that apolipoprotein A can be important in the risk factors, and it is there in the simian species, but also hedgehog. Simian species include apes, monkeys, and human beings. And but only those people who have OXPL. I will talk a bit about that. This particular thing was discovered in 1963 and found to have a complex structure. Over the years, some data has accumulated that LPA can be a cardiovascular risk factor beyond what other risk factors are available with us, and we can see the typical distribution of LPA, and we find that in about 1/5 of the people, the LPA can be more than 50 milligram percent. Now, interesting thing is that statins may moderately increase the risk of LPA, and that could be one of the reasons why residual risk still persists despite a very good control of LDL cholesterol by statins. So this, as I said, residual risk in CVD outcome trials with LPA thresholds account for some of the residual risk in CVD patients, and therefore recent guidelines are to measure LPA levels also at a society level or in patients who are at risk. Now the question arises, why do LPA increase the cardiovascular risk? It is now found that LPA can be pro-atherogenic, pro-thrombotic, and pro-inflammatory. And oxidized phospholipids, which is oxidized form, exists only in human. So therefore, and below it shows the mechanism of pro-inflammatory effect of LPA. So because of this combination of pro-atherogenic, pro-thrombotic and pro-inflammatory factors, it can be a risk factor. And the oxidized form, as you can see, happens only in human, and therefore this oxidized assay can be important in predicting the risk of cardiovascular disease and stroke over 15 years of age. And not only that, the OXPL is also a predictor for calcific aortic stenosis beyond coronary atherosclerosis. So it has again got multiple or more than one or pleiotropic actions or pleiotropic side effects with this particular OXPL. So what are the therapies that can lower the LPA levels or OXPL levels? So some of the drugs are available with us, niacin, for example, and PCSK9 inhibitor that I already showed you, plus some other therapies are also available. LDL-FLS is among them, CETP inhibitors, and Mipomersen. So these are some of the things that can be used to reduce LPA levels. Commonly that we have PCSK9 inhibitors are also available. But are there any specific drugs? Now I come to this interesting drug I already talked about, which is Peclarsen, and the phase 2 study that was carried out with 80 mg dose found that there was nearly 9/10 reduction in OXPL levels with the use of this drug compared to the placebo. So this is very interesting that it is now the potent drug to reduce LPA levels. And so a Horizon study is the phase 3 study with this particular drug, and you can see that the effect is to achieve the target levels of LPA, and these are some of the other drugs that are also available in reduction of LPA levels. So I think a lot of interest is now present in the LPA as well, and it turns out that LPA lowering is an important, and several therapies are being planned and being carried out so that in future we will have a potent LPA reducing agent or OXPL reducing agent. So these were the two studies, and I come to the end of my presentation. Thank you so much.
Thank you, Dr. Sundeep Mishra. You have highlighted the various factors which might contribute to the residual risk and what are the newer medications that have been tried to reduce the risk reduction. Thank you very much. Of course, many of them have been there and has been discussed, like hypertriglyceridemia. LP small a was initially thought of as a very important risk factor. Indians are supposed to have more LPA, but later on it was said that this is no more a greater risk factor. But now once again, studies have shown the importance of LP small a in the cardiovascular risk, and various other medications which have been tried. I think maybe time will show various medications, and which may either in a combination or alone with statin may reduce the risk reduction to a very insignificant levels. Thank you very much, sir.
Thank you.